the Portland service area, which includes just the tri-counties and some of Clark County as well. And one of the reasons why this conversation and this work is so crucial to us at Providence is it's really a lot aligned with our mission. As a Catholic health system, we have a heritage in what Providence characterizes as serving the poor and vulnerable. We might use some other language as well in the work that we do, but really outreaching to those most impacted by social needs and poverty in the community. And as well as just the continued learning that 80% of what impacts someone's well-being are those structural concerns that occur in the community, as well as access to care and other social drivers that our community tells us through our community health needs assessment. So it's really important for us to operationalize that into our work at Providence and collectively move the needle with our other health system partners and the continuum with our community providers.
Thanks. Good morning. I'm Beth Spinning. I'm the Director for Medicaid and Charitable Programs at Kaiser Permanente Northwest. So it's kind of a mouthful, but essentially I'm the business leader for all of our Medicaid contracts within KP. So we have a very large contract with HealthShare of Oregon. We have a contract with Molina of Washington, hopefully contract in Marion and Polk soon, and then a small program in Eugene as well. So as the Medicaid leader, our health plan partners, our contract managers, really expect us to be the conduit for all things Medicaid. It's only about 8% of our overall Kaiser Permanente membership. So just to keep things in perspective, that HealthShare expects us to manage all things health plan related, but then we have to fit into this construct of the bigger Kaiser Permanente. You'll hear me reference this a while because I think we've been on a journey for several years now where the Medicaid payers have been a lot farther advanced in this space than the rest of the healthcare world. And so as Medicaid leaders, we've kind of always known this. I grew up in the behavioral health world and did mental health case management, throughout my career. And so we all know this, and we really worked hard to be advocates for our population and bringing this throughout the years to Kaiser Permanente. But it wasn't really until we had the 2014 and the ACA membership come on that really we took a different lens in looking at it from a population health management perspective, because we had all these new members that were essentially lower income that now had access to insurance and coming into our doors. And our healthcare delivery system saying, whoa, like, we're used to being top notch in quality, and these folks have a lot more needs, and we need to go upstream. It's not just giving the person the colorectal screening and kind of marking the box anymore. We've really got to do something different here. And so that was really the driver for us to say, okay, we've got to look at things differently. Let's try to be more, and we kind of had some fits and starts in terms of how we do this. And I think we partnered with many of the large health systems in Portland metro area on the Housing for Health initiative. So that was kind of one big foray where we said, okay, housing's a big need. And I think, and we'll talk about this now, we have a much more cohesive strategy in terms of capturing information on social determinants of health and how we plan to utilize that in terms of managing our population, working with our community partners and supporting that. So I'm sure we'll talk more about that as we go through the questions.
Thank you.
All right, good morning, everybody. I'm Eric Blake, Director of Operations for PeaceHealth Medical Group, with a focus on care transformation. I joined the organization about 3 years ago to help lead our Transforming Clinical Practice Initiative. There's a mouthful. CMS grant program around care transformation. And that's probably in the midst of about a 5-year journey for our organization around care transformation. Really trying to make our medical group a place where we work as a medical home and a medical neighborhood for our patients. And I think Bonnie's expressed it really well. We're also an organization with Catholic heritage, and a focus on serving those in each community that are most vulnerable, making sure that they have access to the right care, to have the same good outcomes that others might be able to have. So as this journey has learnings about how deeply social determinants impact people's ability to follow a plan of care and be successful, and realizing that we have to address those needs if we're going to be successful in what we're being asked to do with payment reform and everything else going on. So that's the impetus for us, and it's definitely quite a journey.
Great, thank you. Just pass it back. Okay, so you talked a little bit about why this is important and started to begin the conversation on the journey for you as individual healthcare organizations. Give us one example where you saw a success in really using the data in a population health strategy that really was partnering maybe with the community. Give us another example of that. And then more importantly, you guys brought this up on our prep call, which I thought was really important, is what did you learn and what would you do differently? Because Oregon has got some advances, right, that we can learn from, and Washington is kind of in this new world order right now. So kind of talk to us about that. One big moment that you're proud of, and what would you do differently, or what you hope to do differently in the future?
So the first social needs screening that we implemented at Providence, from my understanding, was in 2014 for food insecurity questions at all children well exams. And it was quickly learned that screening is nice to have that information, but we definitely needed some follow-up. We needed some action once we knew that information. And we also quickly learned that food insecurity was a proxy for many other social needs that a family might be experiencing. So at that time, we in the Community Health Division developed a partnership with an organization to start navigating those needs that were positively triggered from that screening. And then that further developed into searching for, looking at other models. What are some of the national best practices to address social needs? What are some of the best screening tools? And, how do we do this as a health system? And so that led us to implement what we call the Community Resource Desk, which is effectively, we released a competitive request for proposals to a couple high-performing community agencies that was doing this work. We knew that Providence couldn't both be a health system and a social service agency, and nor did we want to. So the partnership that we developed was with a community action agency that effectively operates a satellite location right on some Providence campuses, and that is still going strong, and we've been able to expand across our region. And developed a screening tool that we worked really hard with our health literacy folks to make sure that it would be user-friendly to all folks, and then also be able to have those needs that were identified actionable, oftentimes actionable in that moment. One of the things that we also quickly learned was that it's not a one-off interaction, that really a navigator needs to walk through that process with a family for sometimes up to 3 months. And I think the other thing that we learned is that there's not a one-size-fits-all intervention, that we really need to embed equity in this work too. So we made the intentional decision to partner with an organization that offers bicultural and linguistic, that can speak the language of the folks of the populations that our clinics are serving. So those were two big learnings for us, and that's something that we definitely want to be intentional about as we move forward in this work. Right now we're doing, the other thing is that there's a lot of, Providence is a giant organization, and there's a lot of kind of popcorning social needs work going on throughout the organization in different departments. And so it's really, what we would have liked to do earlier is that we did this year, or 2018, was start a Social Determinants of Health Steering Committee. So we're bringing these different stakeholders internally together to be thoughtful, strategic, and implement, hopefully to implement a consistent model across the continuum. So, those conversations are underway, and we think we have all the right players at the table, but it would have been a lot easier to do, or maybe a lot easier to do that work ahead of time. So
great, thank you.
Yeah.
Thank things. Sounds like we've been on a similar parallel journey as we have really kind of built this and tried to infuse this within our everyday work and strategic planning. And I'll say, we had some early successes that have then kind of led us to where we are right now, where we're, kind of tackling the big social determinants of health. So I'll just kind of start there. So we've had clinic navigators and care coordination for many years now, 10, 15 years I think. And one of the big early successes that we had with those folks was actually being able to embed in our medical, our health record, the QEs, right? You guys know what QEs are, so you can grab the data. So the use of certain Z codes that identify social needs for individuals. So when you're working through the EPIC, if you're a nurse or a medical assistant or a navigator, you can actually capture what the social need is. And so that was a big win for us, so that we could start to capture that data and start to understand, oh wow, we have 25% of our population has food insecurity. So those learnings then have kind of prompted us to say, well, now what are we going to do about it? That's the now what, right? It's not just a telephone, handoff to a community partner to get somebody a food box. Let's really look at things a little more comprehensively. So through that journey, we've actually embarked on a national initiative where we are procuring what we're calling a social service resource locator, which is a firm that will actually help us with embedding those resources and the links to the resources within the health record. So what helped me conceptualize that was think about your kind of health plan and your network of providers that you use to provide services. This will essentially be a network of community partners that we use and that we compensate in order to deliver on those community needs that we have. And creating that feedback loop to understand not just was the request fulfilled, but then what are the long-term outcomes for that individual based on what they actually received. So this is a very big undertaking for us as an organization. The Northwest, we are lucky we are the first to implement within Kaiser Permanente across the nation. So we're very excited. At some point in time, once we kind of get it all worked out within our own system, we plan to make this a community asset and actually open it up to other health systems and community partners, so that you could kind of take that platform and either use it through some kind of web-based interface for referrals, kind of working with the 211 system and other systems that we already have in place for fulfillment of those needs. But that's really the grand plan. So I think that from a data collection will really help us. And then similar to Bonnie, we actually now have a very large executive steering committee, so that we can kind of capture all of the things going on, because there were so many things, and you might have one service area saying, we want to do this with our local community. That's great and that's fine, but how are we making sure that we are managing that at a large level and everybody knows what everybody else is doing? So kind of an inventory and work groups and metric tracking, things like that. So we're just organizing that right now.
That's great, thank you.
So I think a piece of our journey I would highlight started about 2 years ago. Like most healthcare organizations, primary care clinics, we've always given out questionnaires and asked some subset of social determinant questions, but they've kind of been entered in the health record wherever that team happens to put them, responded to in a really provider specific way, and that might be not at all, or very robust. It just depends on sort of their level of knowledge and passion about it. So we decided to put a major focus on depression and substance abuse screening. So we implemented a standard process for administering the ESPER screening questionnaires and response to that. And I think I want to speak mostly to the learnings, and that was around working with our individual providers in doing this. When we announced that we were going to start doing that, there was a lot of pushback from our clinicians, and I think it really stemmed from a fear of, well, what then? If we ask those questions and identify the needs, what do we do about it? And they didn't really feel prepared to respond to the needs, and it might be because they didn't know anything about the available resources in the community. Where do I find a behavioral health provider or a treatment program, and that sort of thing. So we went ahead and launched it because we have care management teams that had a lot of that knowledge to share, but it hasn't been completely smooth. And I think one of the things we would do in hindsight would have been more preparation of some training resources and materials for our providers, and go out and spend a lot more time with them, getting them ready. That said, they've really figured it out along the way, and we've heard amazing stories of providers who've said, I've worked with this patient for 10 years and I didn't know they had a problem, and we've never made progress on management of their diabetes or their hypertension, and now that we've addressed this problem, we've made amazing progress in 6 months. So the more that's happened, the more those stories have been spread, the more excited our clinicians have been about participating in it and addressing it. So I think now that we've been through that experience, we're a lot more prepared to tackle the next set of social determinant issues with our care teams.
So I really appreciate highlighting some of those successes and really calling out where the learnings are. And just to kind of recap some of the things that just came out of that last bit, there's a workforce piece here, right, that's really big, about really ensuring that everyone's on level ground and understanding the need and importance of it, the standardized way of going about it, and training and skills building, right, so you're collecting the right kinds of information in the right way. Sharing data across systems is a big one, right, that it kind of is a barrier really to that care continuum. So hearing that. So let's talk a little bit about that. So Kaiser has this robust system that you're piloting right now, and you're figuring out how you do some of that work. What do we really need, though, as it relates to data exchange outside of clinical walls for that care traffic control? And maybe some of the other systems can talk about this. What does that look like, and what do you hope as for your healthcare system moving forward on that?
You want us to go in order or start with?
Either, it doesn't matter.
Well, I'll just share that we are, as well as some other health systems in the Portland Metro region, are really active in the development of the Regional Community Health Network, which is our hub, which I heard a little bit of discussion in this council earlier as well. So, which essentially is a coordinated body where health systems can, are aligned, and they can refer into this hub that is managed by a community-based organization that has a short suite of navigators from other social service agencies that then can network into getting social needs addressed through a series of pathways, which it sounds like there's some understanding about that in this room, how that works. So we're actively engaged in that, and one of the parts of the vision of that work is to have this shared platform, this health information exchange, where both the CLARA system that the community providers use, and then also the health record, EMR, can be integrated into this health information exchange. And knowing right now that communication can be labor intensive between the two organizations. We did pilot that in 2018, but there has to be kind of a more manual feedback loop. So the gold star vision, the North Star, is that we'll have that health information exchange where all those records are coalesced. But that's a very resource intensive lift, and I know that it's underway. There's been a couple grants that the organization has written, but we believe that it's coming because we all believe in the vision. But obviously the issues of HIPAA and all of have to be navigated. We've done a lot of work navigating those internally to talk to legal and IT internally, because we have so many different health record systems just in Providence too. So we're aware, we're aligned in that vision, but it will take some time.
Yeah, just to add on that, because we're also participating in that same regional collective work, but I think my hope is that then things get lifted up, and so you have more of the shared planning and resource at the very highest level, so that from an Oregon, a CCO level, or here within an ACH level, that we can then look at things on the highest level, so that we can make shared investments together. So whether it be like the Housing for Health or whatever the community identifies as the greatest need, how do we leverage all the investments. So we're just not doing our own little thing over here, that we're actually looking at it from an institutional and a true community and regional perspective, so that we can start to deconstruct some of the, the institutional barriers that we've put in place over the last 100 years. That's kind of a grand vision. But I think that it is bold, but I think that that's really the hope of leveraging this data. I wanted to, Eric, you made me think about something on the very member level in terms of a learning. We've had a lot of learnings from our staff as well about collecting this information in a trauma-informed fashion. And I don't want to skirt over that, because I think that's been a very big takeaway for us, that we need to approach this very thoughtfully and make sure that our teams are feeling supported and capable of working with our members to capture this information, because I think that's a real big challenge.
So I think in addition to what's been said, I think a couple things for us, it's continuing our journey of getting good at collecting the data. And sort of along those lines, from a patient perspective, is how do you communicate with the patient what you're collecting and why, and what's going to be done with it, and doing that in a way that creates partnership instead of fear or distrust about, you're going to share this information with other people, because so much of this information is just very sensitive and creates a lot of angst. And I think that's one of the things that we're going to have to wrestle with. I'm sure you all will as well, is how do you become really proficient at that and build trust in the process.
So my favorite part of this conversation is going to move into money. So this is, like you said, this is a bold, adventure that you're embarking on, and you obviously need a cross-sector group of folks, continuing throughout each community you're trying to do this work in as partners with you. And so you talked a little bit about how you're building out using the data in the right way, ensuring the workforce understands, ensuring the end user understands. What are you going to do about that? And then there's the how do we compensate? You use the word compensate for those partners, that are coming to the table. You guys are in the new world order of pay for value, so we know that's your incentive, to be at the table in a new kind of way. And then to bring in community-based partners or social service partners into the mix is another layer of challenge, going way beyond data exchange, But then how do we collectively share risk and get paid for doing this work together, because we're not as good, as we are together. What does that look like, and what is the future?
Yeah, thank you. I think I'm going to take a step, just a little bit of a broader view on that, and I'm sure Beth will have a lot of good insights directly about that question. But I really do want to say that I think ultimately we do want to also commit community benefit dollars and reinvest in the community system that can directly address the structural drivers to these great community health concerns that impact health. And I also wanted to bring up the Housing is Health initiative, because I think that was a really great example of health systems coming together. That was, from the data that was collected from our community health needs assessment that underscored how much housing impacts health. We made a significant investment from some joint investment from our health systems in the Portland metro area to build some affordable housing and to
supportive housing
and that also has healthcare attached to it, with services in healthcare to help our medically complex community members. And I think that those are the types of more, as Beth said, high level things that we need to be thinking about as a health system too, to really reinvest into the community, regardless of payment models. And also I think that our providers and our administrators have learned so much just in this journey that a lot of that behavior and knowledge won't evaporate, that hopefully that'll hardwire into some of this new way that we're approaching medical care and slowly shifting the medical model.
What was the question again?
Money.
That's right. All right, so about value-based payments and money. So value-based payments is really like part of our DNA at Kaiser Permanente. I mean, we essentially are, if you know much about the kind of the LAN framework, we're essentially like a level 4 already because we pay our providers a capitated rate to take care of our members. So unlike other traditional healthcare companies, there's no fee for service and perverse incentives within our environment. We pay them to take care of the member, and we compensate them accordingly. And if members get better, they get paid more, and they don't have to worry about the administrative components because of the way that our clinical practices are structured. If it's clinically warranted, then we cover it as an insurance company. With the exception of Medicaid, where we have to follow the benefits. But from that angle, we were kind of already there on the value-based payment with regard to how we pay for healthcare services, and now we're just now in the realm of figuring out, okay, how do we pay for these other services that we have opted not to provide, and we kind of always ask ourselves, okay, we need this thing, we need this, we need these social services. Do we build it or do we buy it? And we decided that we would buy it because, let's stay in our lane here. We're very good at providing healthcare services and maybe not so good at providing, other, equitable community-based supports. So we have opted to, again, create this network of social service providers that will be part of our network. And we haven't quite figured out how we will compensate them and what those value-based payments will look like, but it may be similar to the other pathways model where you actually pay for the things that you get, right? And then if people get better, then there would be additional incentives built in. So we're just working through those arrangements right now. Initially, it was kind of capacity building and just making sure that organizations have the infrastructure to actually work in this new environment. So that's where we are right now. We leverage our community health investment dollars to do that right now.
Okay, so right now it's coming out of the benefit side.
Yeah, community benefit.
Okay, thanks.
Again, being the last one at the end of the table, probably a similar response.
Yeah, all right, we'll reverse next time.
No real good answers to this, other than our value-based contracts are really forcing us to address social determinants to be successful. So that has driven for us a heavy investment in care management resources, social workers, and nurse case managers over the past few years. But the sticky piece, how do you help pay for then the services that get delivered in the community? I don't know that we've really made that leap, but I think it does come back to something actionable as community benefit. Where do we help reinvest some of our resources in the community to partner? Because much like you've said, that's not our expertise is delivering those resources. We have to find the right partners and help fund those efforts so that they can do what they do best.
Yeah. So just hold that, and I'll just be loud. So in thinking about that, there's also community as partners, not just on the payment model, not just on the data exchange side, but also those folks who are really using the services and bringing them in as partners and helping you with your healthcare reform efforts. Have you guys made any progress in that arena?
I think we're pretty early there, so not really. I love the thing you've done with your community resource desk. We looked at that a while back. That's pretty amazing, so kudos there.
Yeah. Okay. Well, it's nice to have you guys all at the table together so we can kind of get all of the different innovations that are going on and also some of the lessons learned. So here now you have housing and social service and payers and just community-based partners, right, sitting in the room with you today. So now this is the time to have a community conversation around, so what do we do? So we've got these innovations on the way and a lot of good learnings, and you've got all these experts in the room that are actually on the ground in the trenches, right, doing really deep, hard work. And we do have to get to that conversation where we figure out what the payment model, the new world payment model looks like outside of just paying for value inside of different walls. So we have to have that conversation pretty quickly if we're going to make true transformation. I always think about it like, what problem can we really solve together, right? Not all the problems, because you can't do that right now. I think we've, as you said, hundreds of years of putting barriers up. We've got hundreds of years to undo some of this stuff. So what are some of those things that we could really work together as a community? I think this is an opportunity for you guys to now start having a conversation with your healthcare delivery leaders in this region as well around your ideas and opportunities. Make this a what are we going to do about it conversation, not just what's holding us back from getting there. And so let's have that conversation now, but start with some of your ideas. What do you think you could do to partner better with community and vice versa?
Yeah. Well, coming new to this group and the discussion, it sounds like some of this is already happening with the hub resources and pulling together information. But I think that's really one of the key things that I've seen since I've been with PeaceHealth is the difficulty in understanding what are the community resources available out there, and how do you engage with them as a partner, get your patients connected with them as needed. We've experimented a little bit with patient navigators or community health workers, whatever you want to call them. But I think there's still a huge lack of people who are trained in doing that, knowledgeable about the community, and a sort of available resources. I think that's something we certainly could work on is finding opportunities to make that a more attractive role, creating more defined training programs around it, and delivering a body of knowledge that's easy to access, so we can do that better.
Great, thanks.
So I'll kind of speak to this in two parts because I think, it's hard for us as a large organization to look at our different geographies and be able to have one solution that fits every single small area. And so we look at Longview, Kelso, where we have, in that community, very different than what we have here in Clark. And so my hope for and how we kind of look at these things, that we are able to actually take some of these platforms and macro system level solutions and then work with the local community to customize that for that particular geographic region, leveraging the strengths and the assets that are here in this community. And I think that's really the hope that I have, and really the optimism I have about just the ACH work in general. So, I think we've got a lot of, again, experts in this room. What does that look like for our system? What does that look like from a regional, from a Clark Skamania, Klickitat, a regional community solutioning? I'm really excited to have that conversation. I don't know if I necessarily have any answers, but I think that there's a good opportunity here.
Yeah, I agree with what's been said, and I think too, just internally continuing the work to align our social determinant strategy and make sure that we standardize some of that process and the model, but really to continue to keep that community context. And I think that that's something that we in the community health division and also the local clinics really clearly value, and we do work with community partners in local capacities, and I think that it's really important to be continuing that conversation and in forums such as this, but also be at each other's tables too, and co-design that work together and how that's going to look. So I'm glad that that's underway.
Great, thank you. Okay, questions from the council? Thoughts, innovations you want to bring up? And stand up and do it really loud for us, I'm sorry.
Could you speak a little bit to how you included the voice of individuals with lived experience in some of the development of your plans?
I can do some of that work. We do. From our perspective, we have we do the community health needs assessment as part of a non-for-profit health system, and really a lot of that is intentional listening to the community. Like this cycle, we had 20 different focus groups where we partnered with community organizations to make sure that we were including communities that experience intersectional identities and had lived experience with behavioral health concerns, to make sure that we're really embedding that in that data and understanding how to then, from a community health perspective, do investments and understand where, geographically we also really need to focus. So I think that that's really hardwired in that community health needs assessment process, and collaboratively we've been doing a lot better at that. Internally, I think we have some room to grow there, including patient and family advisors and some of our workflows. I know that our behavioral health division just is working now with a community organization that will help us recruit some advisors for some of our clinical work there.
Yeah, I'd say similarly through the community health needs assessment and community health implementation planning that's kind of embedded in that. But then I spoke to kind of the executive steering committee that we have now, where we're kind of managing all things related to initiatives or work related for social determinants of health. And we have members as part of that work, so that we have the member voice recommend at the table and there with us.
So we also go through a very similar community health needs assessment, and that's where a lot of the information comes from about the broad community needs and where we might focus. But at a more kind of boots on the ground operational level, is we're designing day-to-day processes for engaging in social determinant issues. So back to our SBIRT process, we've created patient family advisory councils in each of our core communities. And we often recruit members from those teams to serve on project teams. So we did that with the SBIRT process, and they were involved all the way from the beginning in looking at what's the questionnaire look like, how are you going to present it when a patient comes to the clinic, how will you address the questions that are come up, and of course they brainstormed on, well, here's the questions I would have as a patient or concerns, and then clear through how might the provider address that with the patient. So we've really tried to take that lived experience and that voice and incorporate it into the way we approach the processes, and we'll continue to do that because it's been really powerful and very helpful.
Other questions, thoughts?
I guess I'll just highlight, and Beth mentioned it already, the importance of housing. The fact is that in this area, it's an enormous challenge. Beth, Sam, and I were just talking about how it's growing even just this year, and that families who are middle class are finding themselves without a home in this community. And so that not only is it needed in the Portland Tri-County area, also in Clark County, up in Cowlitz. And the importance of supported housing as an evidence-based practice, that it really does help to improve the social determinants of health of both individuals and families, as well as the enormous need for respite care. Knowing that there are people who are staying in our emergency rooms and our hospitals far too long, spending money that the health systems likely do not want to spend. But the fact is there's very few places to release those folks to where they have a roof over their head. And so I really want to just highlight the fact that those additional respite beds are very, very needed up and down the I-5 corridor. And it is definitely an opportunity for that multi-system collaboration that we saw down in Portland to potentially look at up here. And the fact that not only is our affordable housing system taxed, but our homeless crisis response system incredibly taxed. So anything that the MCOs, the health systems can do to help increase the capacity is incredibly needed. And I know plenty of agencies that would very much like to be at the table here in Clark County to continue that discussion.
Thank you so much.
So this is important. Let's go one step further with this piece, because we want to move to what do we do next, right? Because I really don't want to do the so what, right? Again, what do we do next? So Kate, you talked about what is that multi-partner collaboration, that you've seen some success in Oregon. What does that look like here? And you have a variety of tables going on in this region, right? You're having these conversations. Are you having them with the healthcare delivery systems and the payers in the same room in a roll up your sleeves? Let's come up with the policy barriers, the systems changes we need to make, and some financing models. Is that happening right now?
Not to my knowledge, though there's lots of meetings I don't attend.
So is that something that we could maybe challenge each other to put on the table? I mean, that's a great role for an accountable community health, to be that convening role for that kind of conversation. Is that something that you would hope to challenge your healthcare delivery partners to have with you and roll up your sleeves? And I'm sure that you want to challenge that same back, right? Is to come to the table with ideas, not just all of the problems, right?
Definitely, and I think collaboratively in particular would be helpful.
Right.
And I want to add that we're health systems represented up here. I represent a health plan as well, but having our Medicaid health plans at the table is critical.
Sam?
I think to sort of jump off what both Kate and you said, Robbi, is a question that I have is, all three health systems, it sounds like you're doing these amazing things and you're starting to kind of get more cohesive within your system. I think you said like the popcorn of different areas that it's happening, and you're finally coming together and talking about how to address these social determinants of health. But when you look at the three majors, housing, food, and education, are those sectors at those meetings with you? Because we talk about wanting to have patient voice and lived experience voice, and that's absolutely critical. But I think also these are three enormous systems: food, housing, and education. And systems change is hard, but it's impossible if we're not trying to change the systems together, I think. And I know, at least for me, the cross-section of education and healthcare is so incredibly important to me personally and professionally and to our district, that it's how do I get a seat at your table to say, here are, like, I have some ideas about, the educational social determinant of health and how healthcare may help us address that. And I know I can shout at you from the outside, like, have better provider hours. But, like, how do we have that conversation together to say, here are some of the reasons our kids aren't coming to school, and if they're not coming to school, they're not getting a high enough educational attainment, and then they're either staying in or entering the Medicaid system as adults, and then all of it just comes tumbling down. So I think that would be the question: is like, do you have these other sectors at your table, and if not, how do we get there?
I would say not usually. I mean, we have representatives that work in community health in those areas, and they kind of bring their perspective. But I think we look to more of a broad-based collaborative model where it's not our table, it's our table. And I think that is a good opportunity for this group or ACHs to be the convener and even think about alignment of the community health needs assessments within this particular geographic region, so that you can do some macro level planning across the counties. Anything?
I'm not sure what to add on that one.
I think, absolutely. And I think that at least from my perspective, we've been a lot more engaged with some of our housing partners, but really education and food access. But I think education is one that we have a lot of room to grow. And I know that our children's division was actively engaged with some of the kindergarten readiness work and in conversation with HealthShare in Oregon too, but I'm not really sure the status of those conversations, and I know that there's obviously increasing demonstration of how critical it is for those sectors to work together, especially in early childhood education. So
And Eric, to you, as PeaceHealth being a major footprint in this particular region, what maybe is a role for PeaceHealth and really kind of also being a leader in setting that table, again, being the table that needs everyone at the, I like this, Sam, you said it well, all the sectors that are going to have to make the systems changes with the delivery systems have to be there, as well as the individuals with lived experience or receiving care, to be able to really understand what does that new model look like. And as you're in the middle of doing your own individual reform efforts, and then now you're talking about what does it collectively look like, those conversations have to be happening in parallel to really be coming up with some innovative models. How do we get to payment reform in this is actually making it up at this point, right? Because there's really not a great one out there in the community-based and healthcare delivery in the same sentence. So that doesn't exist yet perfectly. So do you think PeaceHealth could take a leadership role in this region, in that kind of a table, and with an ACH support?
Well, now I'm probably speaking above my pay grade, but I would like to say yes. I would, I think that there's been strong commitment in the work that we've done so far, a recognition of the need to partner. Certainly, we've had folks participating here at the table, So I would hopefully say yes,
Yeah.
but
Well, we videoed
have
you,
to,
so-
Yeah,
right?
I know.
We have to just figure out how to connect with the right people and get those discussions going.
Yeah. Okay.
I'm a civil legal aid lawyer, and I just wanted to find out if you're familiar with a model that's been developed in many places around the country, but in 3 places in Washington State called Medical Legal Partnership.
Yep.
Basically what it is that attorneys or paralegals develop a relationship with particular clinics or hospitals, and medical providers are cross-trained to spot legal issues. And for example, in the area of housing, they might encounter a family that is having a housing problem and trying to prevent an eviction, and then you sort of go back further in the process and realize that maybe, or you might have somebody that's homeless, and you may find that it's not just a lack of affordable or supportive housing, but the family has problems with debt or other sort of bad marks on their credit history that make it hard for them to get a place. And anyway, it's a model that's being developed, and I'm just wondering, 2 of you are nodding that you know about it, and I'm wondering if either of you are doing that in Oregon, and what possibilities there might be for doing it here in Southwest Washington.
Yeah, we have embraced the Med Legal Partnership and now have a lawyer on staff that is what we call a community clinic integrator. And so she actually is kind of program managing the Med Legal Partnership across all sites and service areas for Kaiser Permanente. So I'm not sure. I think we might have, it's just really about a year and a half that we've been doing that. So I'm not sure that we've implemented it all clinics, but the resources available at this point, we're working to spread that.
So you have 1 attorney?
We have 1 attorney, but I believe we have partnerships with outside attorneys to support. So she kind of facilitates that.
Is that operating in Clark County now?
I'm not sure.
Because I know, for example, in our medical legal partnership in Seattle, our Seattle office, they have it with, I think, 2 sites, 2 clinics, and the staff is now 4 full-time attorneys doing that
Wow.
work.
Yeah.
And we have
That's
one
awesome.
in Everett, and I think they're hiring one in Spokane.
Yeah, we have a medical legal partnership too that's not as robust as what Beth described, but the first foyer into that is the for guardianship, and that's for inpatient settings, and we use our community partner that is the manager of our hub for that work too. So they kind of connect that to legal, the individual to legal services, or the family to legal services through that. And we're really, hoping to expand that. We actually have a meeting next week with the Oregon Med Legal Partnership, but I'm not quite sure. I can't speak to necessarily what's on the horizon.
So other ideas like that, questions? Okay, so can we thank our panelists for coming today? And it might be nice, this is a part of the shared learning work that this group is going to continue to kind of spearhead for the region. So this is a nice testing ground to kind of, how do we have these conversations? And then what do we need to do about them? And how do we move that into a more working session with tangible actions that are attached to that learning? We don't want any learning with no action, right? So I think be thinking about for the rest of your time today, as we will talk a little bit about the list of things that are on your minds, but what do we do about those, and what kinds of forums do we need to have these conversations? And although the ACH can be a real holder or container for these types of conversations, this is really a collaborative approach to getting this work done, and what does that look like? And so where do these need to be held, and who needs to host them and lead them? What do you want to try to get to in those sessions? How are they facilitated in a way that actually moves you towards coming to a couple of ideas that you can take action on? Because what you learned in this conversation is they tested a bunch of different things. Some of them worked and some of them didn't. And you got to do that now together, right? You got to test a bunch of things. Some of them are going to work and some of them aren't. And then how do you learn from those and continue to build a model that will actually change the way we pay for this over time? So that's kind of what's next. So I think if you're thinking at your tables, hopefully you can finish out with the rest of the group here today. Thinking at your tables, what that looks like. Write that down on the back of your agenda that I know you're not going to take with you, and write those thoughts down and turn those into Kachina or Daniel to really be thinking, so we can kind of incorporate that into the shared learning series that's going to go on for the next little bit. And I would just challenge you guys to really help this group know and be aware of these opportunities as they emerge, where there might be these tables that they can come to. And I would say back to you all, Kate, I know you've got tables that you're convening, not just in dark alleys, right? They're right out in the open. And let's start figuring out who those right folks are, because you made a great point, Eric. Who are the right people, right? They need to be in that room to have that conversation. And sometimes it's a leadership conversation, and sometimes it's really those folks who are on the ground operationalizing these hubs, or the community connections, the resources, understanding what it means to bring trauma into the workforce development. So we've got to kind of figure out who the right people are in all of these conversations, set them up properly, and take some real action. So again, thank you guys so much for coming, and lots more to come.